Hi, everybody, and welcome to our module on penile disorders. Let's start by briefly discussing the anatomy of the penis. The penis contains three cavernous bodies. These are called the corpora because the word corpora is in both of their names. The first one is called the corpus cavernosa. This consists of two large spongy tissue beds. I'll show you a picture of this in a minute. The second one is called the corpus spongiosum. This is a smaller spongy tissue bed which surrounds the urethra. And the bottom line here is that these corpora are basically vascular structures which can fill with blood to cause the penis to become erect. If you look at the picture on the left side of the screen here, the larger structure is the corpus cavernosum, and it consists of two cavernous bodies, a left and a right. The third cavernous body is the corpus spongiosum. That's the smaller one here, and that surrounds the urethra, which you can see in the picture on the right side of the screen. The urethra runs through the middle of the penis. It's surrounded by the corpus spongiosum. And then on the outside of the corpus spongiosum, you find the corpora cavernosa. That's the larger structure. It wraps sort of around the sides of the corpus spongiosum. There's also a structure in the penis called the tunica albuginea. This structure gets its name because in Latin, the word tunica means covering and the word albuginea means white. So the tunica albuginea is a white connective tissue covering that surrounds the corpus cavernosa, the larger of the two spongy erectile structures. Buck's fascia is also a structure found in the penis. This is a fascial layer, and it covers all three erectile structures, the left and right corpus cavernosa and also the corpus spongiosum. Shown on the screen is a cross-section through the penis. The two large red structures here are the left and right corpus cavernosum. They are surrounded by this white layer here of connective tissue, which is the tunica albuginea. In addition, at the bottom is the third erectile structure, the corpus spongiosum. It surrounds the urethra. And then surrounding all three erectile structures, the corpus cavernosum and the corpus spongiosum, is this gray layer, and that is the Buck's fascia of the penis. Now let's talk about the physiology of the penis, and what you need to understand is how the penis becomes engorged to cause an erection and how the penis resolves that erection. And the key structures responsible for this are the arterioles and the corpora. The corpora are those three spongy tissue beds we talked about before that can swell with fluid to cause an erection. So when the penis is flaccid, there's high tone in the cavernosal arterioles. This is not allowing much blood to flow into the penis, and therefore the penis is flaccid. When an erection forms, this process is called tumescence, and the major physiologic change that leads to an erection is smooth muscle relaxation. The arterioles will have their smooth muscle relax. This will allow blood to flow into the penis, and the corpora also have smooth muscle that will relax. This will allow them to become engorged. So when the arterioles relax, there's more blood flow, and when the corpora smooth muscle relaxes, the corpora will fill with blood and swell. They have structures called sinusoids that can fill with blood and swell, and this will lead to an erection. Also helping maintain an erection is the fact that the swollen corpora compress veins and venules in the penis. This decreases the outflow. So this whole process of high inflow, low outflow, plus swelling of the corpora from smooth muscle relaxation leads to a high intracorporeal pressure, and that's what leads to an erection. The resolution of an erection is called detumescence. This is basically the process of tumescence in reverse, and therefore it involves smooth muscle contraction. The arterial smooth muscle will contract. This will lead to less blood flowing into the penis. In addition, the smooth muscle in the corpora will contract, and therefore the corpora will shrink. When they shrink, they stop compressing the veins and venules, and venous outflow occurs, and the erection goes away. And if you understand this basic physiology of how erections occur and resolve, then it's very easy to understand priapism and erectile dysfunction drugs, which we'll talk about later in this video. Now that we've discussed the anatomy and physiology of the penis, we're ready to discuss penile disorders, and I'll start by talking about Peyronie disease, which many people simply call a bent penis. This is a picture of one on the screen here. It's the kind of thing that once you've seen a picture of it, it's not easy to forget. This disorder is caused by an abnormal tunica albuginea. That is that connective tissue layer I mentioned before that surrounds the corpus cavernosa. It's an acquired disorder likely related to trauma in a susceptible individual. The problem in this disorder is that this connective tissue layer, the tunica albuginea, has a localized spot of fibrosis, and that layer needs to distend equally in order for an erection to occur. If one little part of the tunica albuginea cannot distend, then the erection occurs in an abnormal manner and the penis will look bent like in the picture on the screen here. Sometimes this can cause pain. Men can sometimes feel a nodule in that tunica albuginea layer, and when the penis becomes erect, there will be an abnormal curvature. This is often what men complain of when they come to their primary care physician. And now that we're in the age of iPhones, many men will bring in a picture of their erect penis. It can also cause erectile dysfunction. The treatment is with a drug called pentoxifylline. This is a phosphodiesterase inhibitor. This is its structure shown on the screen here. It reduces inflammation and prevents collagen deposition. Remember, the problem in this disorder is localized fibrosis of the tunica albuginea. It can be given as an injection into the penis or via oral administration. In a penile fracture, there's rupture of the tunica albuginea, so different from the localized fibrosis seen in Peyronie disease. This is often associated with damage to the urethra, and it's often caused by blunt trauma. Men will say that they heard an audible snap after a trauma, and they will present with pain, swelling, and ecchymoses, which is bruising of the penis. Next, let's talk about priapism, which is a persistent erection that lasts more than 2 to 4 hours and is not due to sexual activity. And in terms of step 1, what you want to know about priapism is that it usually involves a failure of those mechanisms of penile physiology we talked about before. So in order for an erection to occur, we said that the corpora have to relax their smooth muscle. For the erection to resolve, the corpora have to constrict their smooth muscle. So in most cases of priapism, the corpora fail to constrict, and that's what leads to priapism. There are 2 types of priapism. The first type is called ischemic. This is the most common type. It's responsible for 95% of cases. In ischemic priapism, there is a lack of outflow from the corpora so that the corpora remains engorged and the erection persists. The problem is because blood is not flowing, this will lead to tissue ischemia. There's also a non-ischemic form of priapism. This is sometimes called high-flow priapism. In this form of priapism, there's a fistula between the arteries and the corpus cavernosum so that blood continues to flow. This often follows trauma. So these men don't have a problem with outflow from the penis. They just have too much blood constantly flowing into the penis. And when a man presents to the emergency room or to a provider with priapism, one of the things you actually do, believe it or not, is perform a blood gas of the blood that is present in the erectile tissue. In the setting of an ischemic priapism, what you will see is very low oxygen content because blood is not flowing and oxygen is being consumed by the tissue. You will see very high CO2 content because metabolism is ongoing and the CO2 is not being moved away by blood flow, so the CO2 level builds up. And because the CO2 level is high, what you will see is a low pH, and the low pH is toxic to tissue, so this is why necrosis can occur and why ischemic priapism is dangerous. In non-ischemic priapism, what you will see is normal oxygen, normal carbon dioxide, and normal pH. Basically, what you have is arterial blood just flowing in and out of the penis at a high flow rate, and that's leading to the priapism. Very high yield for you for step 1 to understand that the blood gas will be different in the setting of ischemic versus non-ischemic priapism. So let's talk about the etiologies of ischemic priapism, the more common form of priapism. In general, ischemic priapism is caused by a failure of cavernosal outflow, so the corpora become engorged with blood, but blood will not leave, and therefore priapism occurs. And there are 2 classic causes of this. One is sickle cell anemia, and the other are certain classes of drugs. So in sickle cell anemia, blood cells can sickle, and this can occlude veins and venules. This can block venous outflow of the penis, and that can lead to priapism. And then there are a number of drugs associated with ischemic priapism, and the way to remember all these drugs is by some mechanism they block smooth muscle contraction. So remember, for an erection to resolve, smooth muscle contraction must occur. The arterioles must constrict so less blood flows into the penis, and the corpora must constrict so that they shrink in size and allow blood to flow out of the veins in the penis. Remember, in an engorged penis, the corpora are swollen and they compress the veins so that blood cannot leave. The corpora must have their smooth muscle constrict for an erection to resolve so that the veins and venules open up and blood will begin to leave the penis. So anything that blocks the smooth muscle contraction is going to potentially cause priapism. So first of all, there are a couple of antipsychotics and antidepressants that sometimes do this. Trazodone is famous for this, so are some SSRIs. And then alpha blockers can do this, and that should be easy to understand. These block vasoconstriction, and therefore they relax smooth muscle. That can block smooth muscle contraction. So drugs like doxazosin, tamsulosin, terazosin, prazosin, these are all given for hypertension or sometimes for BPH. They can cause priapism. And then finally, erectile dysfunction drugs, which we'll talk about later in this video. The goal of these drugs is to cause smooth muscle relaxation in the penis. So that can be a good thing for causing an erection, but it can be a bad thing for resolving an erection, and that can potentially lead to priapism. Ischemic priapism is a urologic emergency. As we talked about before, there's low oxygen content and acidosis of the blood in the penis. This can cause permanent erectile dysfunction. It can potentially even lead to penile necrosis and gangrene, so it needs to be treated immediately. One of the treatments is corporal aspiration. This simply involves using a needle to remove blood from the penis to lower the pressure. Sometimes intracavernosal phenylephrine is injected, so the idea here is that this will activate those alpha receptors and constrict smooth muscle and resolve the erection. You can basically think of the sympathetic nervous system as being the system that blocks an erection. You wouldn't want an erection as part of the fight or flight response. So anything that's going to activate the sympathetic nervous system like phenylephrine is going to cause vasoconstriction in the penis, and this will make priapism go away. And then lastly, surgery is sometimes necessary to resolve priapism. Condyloma acuminata is also called genital warts or anogenital warts. This is a sexually transmitted infection caused by human papillomavirus subtype 6 and 11. It leads to lesions on the penis that are described as soft, tan, or cauliflower-like. This is a picture of one on the screen here. In a board question without a picture, the lesion may be described as verrucous, which means wart-like. And in addition to the penis, HPV can also cause lesions in other areas like the vulva in women or the perianal area, which can lead to rectal bleeding. The treatments are with various chemical agents that resolve the warts or surgical therapies, and importantly, this does not lead to cancer. You may be aware that certain subtypes of HPV can cause cancer, but not the same subtypes as those that cause genital warts. There is one histologic hallmark of condyloma acuminata that you should be familiar with. This occurs in many cases of HPV infection. Cells that are infected with the virus will show perinuclear clear vacuolization, which is called poilocytosis. What this means is that the nucleus will look sort of raisin-like and surrounded by clear space inside of the cell. That's what's shown right here. That's called poilocytosis seen in HPV infection. Squamous cell carcinoma is a rare penile malignancy. It arises from squamous skin cells and occurs in the glands or the shaft of the penis. It usually occurs in older men about 60 years of age. It's rare in the United States and Europe, and it's much more common in places like Africa and also Asia and South America. Some risk factors for squamous cell carcinoma are shown on the screen here. The first one is an uncircumcised penis. So when the foreskin of the penis is left intact, debris can accumulate underneath of it, and this can lead to exposure to the squamous cells in the penis to carcinogens. When boys are circumcised, meaning the foreskin is removed, it's believed that these children have reduced exposure to carcinogens, and therefore they have a lower risk of squamous cell carcinoma of the penis. HPV infection is also a risk factor, just like it is for cancer in the cervix. HPV DNA is found in 30 to 50% of cases of penile squamous cell carcinoma, and it's usually type 16 and 18, the two subtypes that also cause cervical cancer, and different from the subtypes that cause genital warts. And then finally, smoking is also a risk factor for penile squamous cell carcinoma, the same way it is a risk factor for cervical cancer. There are a couple of classic pre-malignant lesions for squamous cell carcinoma of the penis. All of these are examples of in situ carcinoma, meaning they are neoplasms with no basement membrane invasion. The first one is called Bowen disease. This is the presence of a gray-white plaque on the shaft of the penis. It's an example of leukoplakia. Second one is called erythroplasia of Carra. It's a dark red lesion on the glands of the penis. It's an example of Bowen's disease on the glands. When it occurs on the glands, it looks dark red. When it occurs on the shaft, it usually looks white like leukoplakia. And then the third example is Bowenoid papulosis. This is the presence of multiple red-brown papules on the penis. I don't have pictures of these to show you, but if you Google the names, you will find classic pictures, and just be aware that if one of those is shown to you in a board question, they're describing an in situ carcinoma of the penis, a pre-malignant lesion for squamous cell carcinoma. I'll finish this module by talking about erectile dysfunction, which is the most common form of sexual dysfunction among men. Erectile dysfunction is defined as the inability to achieve or maintain an erection, and you should be aware for your board exams that there is usually a psychological component. So this may include anxiety about sexual performance or some other fear or worry in the man that contributes to the erectile dysfunction. Most cases are a mixture of psychological and organic causes. In terms of the organic component of erectile dysfunction, this disorder is associated with many conditions. It's not understood exactly how these conditions lead to erectile dysfunction, but many patients who have erectile dysfunction also have one of the things listed on the screen here, like heart disease, hypertension or diabetes, also obesity. There are a number of drugs, especially antidepressants, that are associated with erectile dysfunction. Smoking, alcoholism, and other forms of substance abuse are also associated with ED. And then finally, men who have sleep apnea are more likely to develop erectile dysfunction. So we don't know exactly what causes erectile dysfunction, but we do have some drugs that work fairly well to treat the condition. And the drugs that are usually used to treat this condition are phosphodiesterase 5 inhibitors. These drugs have names like sildenafil, which is also called Viagra, and vardenafil and tadalafil. The reason that inhibiting phosphodiesterase 5 helps in erectile dysfunction is because PDE5 breaks down cyclic GMP in smooth muscle cells. Therefore, when you inhibit phosphodiesterase 5, there's more cyclic GMP in cells, and this leads to relaxation and an improved response to nitric oxide. To understand this, let's look at a smooth muscle cell like I've drawn on the screen here. So in order for this cell to relax, what has to happen is that cyclic GMP has to build up inside of the cell. Now, nitric oxide is very important for building up cyclic GMP because it activates the conversion of GTP to cyclic GMP. Cyclic GMP is then broken down by phosphodiesterase 5 into GMP. So if you inhibit phosphodiesterase 5, the level of cyclic GMP will go up, and that will lead to relaxation. And just like we talked about earlier with priapism, relaxation of the corpora is very important for maintaining an erection. The corpora need to have their smooth muscle relax so that they can fill with blood and become engorged. You also need smooth muscle relaxation in the arterioles so that blood will flow into the penis. So by relaxing smooth muscle cells in arterioles and the corpora, that leads to an erection, and that's why phosphodiesterase 5 inhibition helps with erectile dysfunction. Because these drugs generally relax smooth muscle, they have a number of uses, not just erectile dysfunction. So in erectile dysfunction, smooth muscle relaxation leads to improved blood flow to the penis, and that's why these drugs are helpful. In pulmonary hypertension, smooth muscle relaxation in vessels in the lungs lowers the pulmonary vascular resistance, and that lowers the blood pressure in the lungs. And then finally, in benign prostatic hyperplasia, or BPH, these drugs relax smooth muscle in the bladder and the prostate and make it easier for men to urinate. And one of the drugs in this class, tadalafil, has FDA approval for treatment of BPH. The side effects of PDE5 inhibitors are very easy to understand if you understand their mechanism of action on smooth muscle cells. These drugs are contraindicated in patients taking nitrates. The combination of a PDE5 inhibitor and a nitrate can lead to life-threatening hypotension from massive vasodilation. This means that men who take nitroglycerin or isosorbide, usually for coronary disease, cannot also take a PDE5 inhibitor for erectile dysfunction. To understand this interaction, let's look at my drawing at the bottom of the screen here. So nitrates work by raising the level of nitric oxide inside smooth muscle cells. If you simultaneously inhibit phosphodiesterase 5, that can lead to dangerously high levels of cyclic GMP. That can lead to massive vasodilation and life-threatening hypotension. Other side effects of these drugs are also related to their smooth muscle relaxation properties. So headache can occur from vasodilation in blood vessels in the meninges, and flushing can occur from vasodilation in the skin. And then, as we talked about before, priapism can potentially occur because these drugs relax the smooth muscle in the corpora, and then that smooth muscle may be unable to constrict to resolve an erection. And then the final side effect is bizarre. It's just something you have to know about these drugs. They can potentially cause vision problems. Some men temporarily notice slightly blue tint to their vision. This is called cyanopia. This is mostly reported with sildenafil, which is Viagra. It's believed to happen because these drugs cross-react and inhibit phosphodiesterase 6 in the retina, and it usually resolves within hours. It's not serious, but patients may complain of it, so you need to be aware of this side effect. And that concludes our video on penile disorders.